And as part of my lean leader certification, I'm happy to be the co-lead on RPIW 43, which involves processes in the Child and Youth Development Clinic. Our target for the week was to establish an efficient information flow and to establish processes which support a fair and equitable access to services into the assessment clinic. So this is our standard work combination sheet, which shows our team members and our participants today, and we'll be operating to attack time of 20 minutes. So we have to talk fast. Here's our team picture, great looking bunch. I'd like to acknowledge some team members that were unable to be present today. Matt McCaws, a psychologist with the Sask Rivers Public School Division. Tricia McEwen from Student Support Services, the PA Roman Catholic Separate School Division. And also missing is Ellen Montour, consultant from Autism Services. Coming from organizations who all interact with this clinic, all of these team members were able to provide us with some very valuable insights into the processes. So our project form. So as I said earlier, our target was to establish some efficient information flow, establish processes which support fair and equitable access into the services, into the Child and Youth Development Clinic. So the current situation, the Child and Youth Development Clinic is an assessment and diagnostic clinic for fetal alcohol spectrum disorder, autism spectrum disorder, intellectual disabilities, and complex neurodevelopmental disorders. The clinic has a full-time coordinator, as well as a 0.7 FTE psychologist, which is shared by 2 psychologists, and part-time 0.2 FTE occupational therapists. So a fairly small group doing a lot of work. The clinic works in conjunction with and support from a large number of external providers to function, such as the Child Development Services, speech-language pathology, occupational therapy, psychiatry, pediatricians, school psychology, and also school counselors. So currently, yearly demand is actually 147 total client referrals, 74 which are on an existing wait list, and 73 from the 2014-2015 year. As of June 2015, there's currently a 27-month wait list. Some referrals into the service have already had assessments completed and have also received a diagnosis. So there's an initial screening process, which includes an in-depth review by the clinic coordinator. The screening team then consists of the coordinator, the 2 psychologists, which meets at a minimum monthly. There's sometimes a delay in confirmed diagnosis can delay financial and human resources for the clients. Triage into the assessment clinic is based on a first-come, first-served basis, except for those children who are not attending school on a full-time regular basis. Children whose birth mothers have disclosed prenatal alcohol consumption during the screening process. Children for whom a lack of diagnosis presents a barrier to accessing appropriate services. And lastly, ministerial referrals. The multidisciplinary diagnosis team includes a pediatrician, general practitioners, psychologists, occupational therapists, speech-language pathology, and clinic coordinators. So our RPIW theme, by revising eligibility criteria for assessment and clarifying the referral sources, we will provide services to the right people in the most efficient manner. A streamlined screening process will improve intake into the clinic for assessment and diagnosis.
Hi, I'm Trudy Price. I work as a data coordinator in materials management, and I am co-lead on RPIW 43, working towards my lean leadership certification. The first thing we are going to have a look at is our current state value stream map. Referrals are received to the Child and Youth Development Clinic. There's a wait. That's until the clinic coordinator processes the referrals, which means she is collecting information, making phone calls, emailing, sending letters, all to collect the information required to make an accurate disposition decision. And then the referral waits until the next screening meeting, and that happens at a minimum of monthly. Referral goes to the screening meeting where it is reviewed by the clinic team. If the team has enough information to make a disposition decision, then from the screening, a decision is made to move the client on either to the wait list, onto active, or on to redirect. If the team feels they do not have enough information to make an accurate disposition decision at this time, then the referral remains in the screening cycle until enough information is gathered to reach a disposition decision. Waitlists include referrals that are waiting for their assessment to begin. Active clients are those that the Child and Youth Development Clinic are in the process of assessing. Redirect are referrals that an assessment and diagnosis is not appropriate for this team, but they can be redirected to other services. We decided to focus on the clinic's team screening meeting process because, as you can see, this particular process step could take up to 63 days before a disposition decision was made. There are two parts to this process box: waiting for external providers like school professionals and clinic providers to complete assessments or provide information or confirmation of prenatal alcohol consumption for an FASD assessment. Our starbursts indicated in current state were issues of information gathering or receiving incomplete information from referral sources, and that led to the clinic coordinator having to send numerous emails, make many phone calls, and the long waits for this information to be received. Our other starbursts consisted of issues around disposition, such as second opinion referrals. Which of these clients that have had a diagnosis at our clinic or elsewhere and would like another opinion as to whether the diagnosis was correct? Now we're looking at the baseline of our target progress report. There are four areas we choose to focus on. The first was the productivity of the screening meeting. We felt that the clinician's time could be better spent on client care tasks rather than spent discussing clients that were not ready for a decision to be made. There were 7 disposition decisions made in the 60-minute meeting that we observed. The second thing we looked at was our setup time. The value we chose to measure was the amount of time it took a school student support worker to complete the referral form. We wanted to make sure that any changes we made to the referral form to make the clinic coordinator's job less cumbersome did not result in offloading additional work to the referral source. The cycle time was from the beginning of the screening meeting until the halfway point of the screening meeting where a disposition decision was made. This was identified as 30 minutes. Capacity. Baseline time for clinic psychologist hours per year were 878 hours, which allowed them to assess 48 ASD clients per year or 46 FASD clients per year. Why we feel this is a relevant capacity measure is because there is a limited amount of psychologist time to do the assessments. And now we're going to look at TAC time. Our TAC time was based on the current process for a referral in a screening meeting, which is 9 minutes per referral. This means that they could spend 9 minutes in total discussing each client in a screening meeting.
Hi, my name is Gloria Jansen. I'm the clinic coordinator for the Child and Youth Development Clinic. I'm the only paid full-time staff for this clinic. My role is to receive referrals, speak with families and legal guardians about their concerns, and gather information from professionals who previously completed testing or provided support to the child and family. I coordinate the assessments and am the main contact for the families as they go through our assessment process. I also record and track information related to referrals, diagnostic outcomes, and length of time between significant events in our referral and assessment process. Up until now, I've been using a series of Excel spreadsheets to organize the information, which has meant entering some information more than once in order to link all of the data, or cutting and pasting other information so it could go onto a contact note that can be added to the child's chart. Now, thanks to Libby Stroman's extraordinary expertise, I will be using a Microsoft Access database to record this information. With this new database, I will no longer have to repeat entering parts of the data to create those meaningful links between the information. Our team will be able to access information that is more diverse and provides a better picture of our screening and assessment processes. My days of cutting, pasting, and reformatting onto a chart note will end, as I will be able to use the report format, which, oops, yep, it's right there, to summarize our screening process, and with a couple of mouse clicks, print a summary that can be added to a child's chart. There will be a steep learning curve for me to become proficient, but in the long run, I think it's going to be a beneficial change. So thank you, Libby, wherever you are.
Hi there, I'm Christina LePage, occupational therapist with the Pediatric Early Developmental Services team from the Therapies Department. Together as an RPIW team, we brainstorm strategies to reduce the length of time children and youth are waiting for diagnostic assessment with the Child and Youth Development Clinic. Changes were made to the referral process. First, we changed the access to the clinic. Initially, CYDC accepted referrals from any source: family members, child care workers, social services workers, and health professionals. We shifted away from this open referral access by narrowing the accepted referral sources to the healthcare, mental health, and school professionals only. This was decided in response to the acknowledgement from senior management that the Child and Youth Development Clinic is a specialized service. Initially, this may seem to be a barrier for families to access health services. However, we have all heard stories from our families about feeling isolated and alone in their journey navigating healthcare services. Filling out forms, trying to capture their child's complex needs is a daunting task. Changes surrounding the referral source facilitate engagement of our families in a supportive fashion. They will now work with their family physician, nurse practitioner, school team, or therapies team to complete the required referral information. With this change, we were able to tweak the current referral form, tailoring the language and format for the professional community. We made some wording changes that will help ensure the thoroughness and completeness of the submitted referral form. It is anticipated that this will decrease the information gathering time by our clinic coordinator in preparation for the assessment. These changes will also facilitate the appropriateness of referrals and that the CYDC assessments are offered to the priority children and youth of our communities. We also added a checkbox there. So that checkbox was requesting permission to share the referral to other relevant PAPHR services, including autism services and the cognitive disability consultant. This was done in an effort to provide seamless access to potential support services for families while they're waiting for their diagnostic assessment. We tested these changes by consulting with school personnel, with Matt and Tricia's support, with the PEDS team members, and with Victoria Square pediatricians. We received positive feedback regarding the streamlining of the referral content, the quick tick boxes, and the easy ability to link families to relevant developmental support services. Overall, we feel confident that these changes will enhance the referral process to the Child and Youth Development Clinic. Thank you.
Good afternoon, everybody. I'm Dr. Lindsay Foster, and I'm a psychologist working part-time with the Development Clinic. So I'm going to discuss two major changes that we made to our screening meeting. So the overall purpose of our screening meeting is to really ensure that those children and youth who do go on to our wait list are appropriate for our services, and to quickly respond to referrals that aren't appropriate for our service. So whereas we used to discuss the status of all the referrals and get updates, even for the individuals for whom we only had part of the information, now the meeting is only going to focus on the brand new referrals or those youth where we actually have enough information in order to make a decision. So this should reduce the overall time to screen and open up more time for other clinical activities. We also created a template letter for those individuals who aren't appropriate for our services. So the letter will clearly explain why we're not the program that they're looking for and tell them how to get to the right program, including contact information for all those other alternatives. Okay. So this should help point people in the right direction. And there's the template letter. So we also clarified the eligibility criteria for clinic services. So I think through this RPIW, it was made more clear that we're not a full-time clinic, and that the reason that we've been successful for the past 10 years is because we have our colleagues from the school and the pediatricians who serve as members of our team and do this extra developmental work in addition to their regular workload. So we are dependent on external collaboration to have our team run. And it was acknowledged that given this limited capacity, our clinic would focus on youth who've never had a diagnostic assessment and will no longer be providing second opinion services for youth who have already had a diagnostic assessment elsewhere and have already received recommendations. So this will reduce duplication of services. We've also added clarification of which diagnoses we do assess for and which we do not on the program brochure, which is accessible on the website. And this will include information about where people can get other types of assessments they might be looking for, such as learning disabilities assessments. And while I have a public audience, I just want to thank Gloria Jansen, our clinic coordinator, for all the hard work that she does to support our team, but more importantly, all of our clients and their families.
Good afternoon. My name is Gloria Cullum. I'm participating as a parent advisory. First off, I would like to thank the wonderful people who make up this amazing team for inviting me to participate in this RPIW. As a foster parent that supports the development of children with FASD, this was a great learning experience for me. I just wanted to add, like the other lady said, things don't just go poof and my child's in there. It's a whole lot more. I learned that there are many different obstacles that the team faces in order to be adequate and efficient to meet the needs of our communities. It also gave me a greater understanding of the process and all the hard work that it takes to make such a difference in the quality of our children's lives. As a foster parent, it is a great, and a parent of course, not just a foster parent, to be able to access information that will benefit the children. So that is why the Child and Youth Development Clinic has tweaked the brochure and made sure that it's accessible to the public. It's created to be very useful, and it explains quite simply what they do, who's involved, how to refer, and also the bottom part where there's other information and there's numbers to, if you have any concerns, you're pointed in the right direction as how you can access whatever it is that you need from the Child and Youth Development. Thank you.
Good afternoon. I'm Claudia Driscoll, and I have been invited as a participant and a family patient client representative. As we have been talking about, one of the big goals was to reduce our wait list. The question that we all asked ourselves is, how can this be done with the current resources, or human resources, and the present and growing need for the services? All participants worked respectfully of each other, trying to find solutions and ways to reduce the waiting list. Where did we begin? Tools were already in place, but as we updated the brochure and put online to clarify the criteria for referrals. The second was to revamp the referral form with clear instructions that when the form is not complete, the form would be returned to the referral source. All participants had to come to terms of the program mandate and will and must, may it be harsh, but it's to themselves to say no if referral is not appropriate. The screening team will contact referral source and direct them to, or redirect them to services that can help. The conclusion, yes, today can reduce wait list by looking at content of the referral and asked, does this referral meet the criteria? If not, off the list. Future, how will the team meet the present and growing need with the current resources? Finally, I just want to say how proud we all should be of the staff in this program for their caring, compassionate, friendly, and committed to helping families in need.
So just quickly talk about our 5S. We made improvements and quickly did a 5S in the OT family room. It was originally 1.3, we made it up to a 3. We did a lot of cleaning, labeling, sorting. That's before and after. And next is our newspaper item. Oh, we put in a nice cork wall there to help with soundproofing. So, our next is our newspaper. Some items that were still outstanding. A lot of them pertain to rolling out with the new processes. Excuse me, to the referral sources. Some of the new database has to be finished up, and the new brochure has to be put on the website yet, and will also be sent out to the school divisions. So our value stream map here in the future, we just want to say that we did make some gains in our screening process, which is where our focus was. The lead time originally was 952 days, and by changing our processes, it's now reduced to 70 days. Our target progress report, some of the things we looked at, the productivity went from 7 disposition decisions in 60 minutes, and we changed that to 5 disposition decisions in a 10-minute meeting. That was a 400% increase in productivity for the screening meeting process. Our setup time was improved when the referral form was being filled out. We reduced time to fill that out by 43.75%. Our cycle time was improved. Our target was set for 20 minutes, and we were able to reduce that down to 10 minutes and 45 seconds, reduction of 82%. And lastly, our capacity was our last area where we made improvements. Reduction time that the psychologists spent in screening time are now able to devote more time in assessment and diagnosis and potentially see more clients in a year. Quickly, our summary. So we improved access to information about the clinic for referral sources, clients, and families. We're now being defined as a specialty clinic. We developed more specific criteria for our services. We developed more useful responses to referrals that do not meet our mandate. We removed bottlenecks in the intake and screening process, and bottlenecks remain in the timely access to the assessment portion of our services due to the lack of human resources. If additional human resources do become available, then these improvements will allow the clinic to better meet demand. Big thank you to everybody that participated, and specifically Brett Enns, our sponsor, and Jen, our process owner, and the big thanks to Allison Gillespie, who supported it and gave us quite a bit of support.